All right, guys, we're back. We are going to go over, I'm hoping that I have the 2005 ACLS, or excuse me, the PALS video up for your assessment, because I think that it's probably one of the best ones. So if you haven't seen that yet, go ahead and go back. You need to watch it, okay? So let's go over some of the things that we're going to look at when we do the general approach to the pediatric patient. I think that it's very important that you do so in a systematic approach with these guys. PALS, as a matter of fact, is 99% about the systematic approach to assessing a child. All right. Parents and caregivers, you want them involved. You want them to help maintain the calmness for the child, and pay attention to the way the parents and caregivers interact with the child. And again, remember that personal safety is your first priority. Yes, these guys like to kick, scream, bite. Be careful, okay? And they're quick, where you think that they are extremely quick. So look for the hazardous situations. Again, standard precautions. Again, and if there are any type of infection, rashes, you should probably make sure you got your respiratory and a gown on. That's probably a good thing to do. Again, look for your clues of what caused the problem, the mechanism of injury or the nature of the illness. And again, note the presence of any dangerous substance. Pennies lying on the floor, medication bottles that are opened and that should not be because they think that they're Flintstones. Or there's a whole thing of Flintstone gummies that are now missing. That's probably a good idea. Look around the environment, check for signs of trauma, look for evidence of child abuse on these guys. Objects being used that just happen to match the bruise would be good. And then pace your approach to give the child, when you can, let that child adjust to you, especially when they're there. Simple words, speak softly until you can gain confidence and trust with these little ones, okay? Again, eye level. Get down to the eye level and start to bond with that child, okay? And again, if the one person bonds with that kid, I would say let that person continue to do their thing. When we're talking about the primary assessment of these kids, we're talking about the pediatric assessment triangle. And again, if you hopefully you all watched the video already, but the pediatric assessment triangle is appearance, work of breathing, and the circulatory status, okay? Long and the short, is the mental status and muscle tone where it should be for the kids, okay? Is their breathing, are they having to work to breathe, or they have a rapid or slow breathe? If there's a problem with the breathing, okay? And then circulation, if it's anything but pink, it's a problem, okay? Pink is good, anything but pink is bad. All right? Okay, so again, oops, sorry guys. Employ the ABPU method. Don't sit there and try to do the Glasgow Coma score. Yes, is there a pediatric Glasgow Coma score? Yes. Is it different from infant, child, and adult? Yes, it is. And, by the way, ABPU works really good. Okay? Stick with ABPU. Never shake an infant or a child. That's kind of a no-brainer, but yeah, we don't shake these guys. Even relieving an airway obstruction. No, we don't shake them. There's a deliberate movement that we do to do that. Okay, so is the airway patent? Is the airway maintainable with head positioning? If the airway is not maintainable, where we have to go in and perform a more advanced airway. Guys, 99.9% of all patients, simple head positioning, good suction techniques, and use of an OPA or an MPA. And when I say OPA or MPA, usually just the OPA does it. Great job. So again, you can open the airway of a child. I would probably not stick anything in their mouth. Again, especially if you think that there's a foreign body. If there's a foreign body, you should be immediately grabbing your laryngoscope and going after it. Okay, so again, this is the head tilt chin lift method. Again, jaw thrust maneuvers. Notice how we got some padding up underneath there. Again, looking for the chest and the abdomen to move. We want to listen for breath sounds. And then again, one other thing with the primary assessment of a pediatric patient with breath sounds, think about pulse oximetry. Okay, get that pulse ox. And put the pulse ox either on the finger, I've used the big toe, guys. The big toe works really good. If they're a really tiny kid, you're probably going to have to do the one with the tape. But I want the little Band-Aid type material. But I'm going to tell you this right now. These kids hate that, okay? And so keeping this pulse ox on might be a little bit of a trick, okay? So, but pulse ox does actually tell us a lot of things about a kid and how their status is. Again, if you suspect trauma, check for the life-threatening chest injuries. The respiratory rate, notice that. Are they breathing faster for what they should, or not as fast as they should be? Guys, anytime that any pediatric patient is below 10 breaths a minute, it's usually a very bad thing. Anytime that you're above 40, unless they're like a really teeny tiny neonate that was just born, that's usually a sign it's an ominous sign, okay? So again, the effort, make sure that the air is going in and out and you're hearing good lung sounds. You should hear air movement, okay? If you're putting your stethoscope up there and their chest is going up and down, oh, I'm not hearing anything, as in I'm not hearing air going through at all, you're probably a step away from them coding, okay? So again, check, cyanotic is a fairly late sign for these kids. They're going to get really pale and mottled, and then they're going to go to the cyanosis, okay? So check the circulation, and again, check your capillary refill time, okay? These are all things that's part of the first thing. If you're seeing anything like nasal flaring, pursed lips, using accessory muscles to breathe, the diaphragm is really moving hard, okay? These are using the abdominal muscles to support them, to support the diaphragm. If they're grunting a lot, these are all really bad, terrible, horrible signs, okay? Now, the heart rate. Again, kids go tachycardic in response to stress, okay? If they're in a bradycardia, that's probably because the oxygen has run out, and it's an ominous sign. You need to start bagging that kid right then, right there. No questions asked. Go for it. All right? Peripheral pulses are a good indication of end-organ perfusion. So if I lose my distal pulses, I'm kind of worried, okay? If I can't feel a central pulse, which is usually a brachial or a carotid or a femoral, yeah, we've got a major issue. The little tiny babies, again, it's the brachial, all right? So, again, if I've got good ones at the brachial or the radial, but then I got weak ones at the periphery with bad capillary refill, I probably got some major problems with our end organ perfusion, okay? And by the way, usually when they start not getting blood to their brain, seizures are very common, okay? So make sure that you keep that in mind. Is a reason that these kids are having seizures is because they, excuse me, I'll get the lights back on. There we go. All right. So again, the impairment of the brain, again, the brain is a nutrient hog, and especially in kids, all right? So keep that in mind, keep aware of that, all right? Again, early recognition of problems is kind of our goal in PALS. It's kind of our goal in our pediatric care, is to identify, again, by the way, when they're not producing urine, newsflash, there's something seriously wrong. They're in a shock state, they're dehydrated. So again, one of the things we really need to ask these parents is, hey, how many diapers has he gone through? Well, you know what? For the last 3 days, he's been going through 10 diapers a day, and now I think he's still got the same one on for the last 24 hours. Uh-oh, there's a clue, okay? So again, things that are going to cause an arrest. Once a child goes into arrest, the chances of you getting them back are very, very poor. So let's prevent them from getting to that stage. If they got a heart rate of greater than 180 or less than 60, I would be extremely scared. By the way, they can tolerate tachycardia a little bit longer than the adults, but remember, they're burning up oxygen while they're doing that, okay? If their respiratory rate's greater than 60, you've got some problems, okay? Trauma, again, be ready for that patient to go into an arrest state. They throw a blood clot, they get a pulmonary embolism, the pulmonary contusions. Again, where you think that they don't have the injuries, they end up having the injuries and causes a lot bigger problems, all right? Again, burns, and it's usually because they end up having airway burns, okay? Any type of altered level of consciousness, seizure activity, fever where they're breaking out into rash, which is that small little dots, is the petechiae, okay? The bigger, by the way, blotches, purpura, yeah. If you're seeing purpura, hopefully you've got your gown on at that point. Your gown and definitely your N95 on, okay? So the progress deteriorates into respiratory or cardiac arrest. And by the way, kids, that's how they arrest. They don't arrest by going into VFib. The only time they usually go into VFib is when they stick their finger in a light socket. Yes, they do that. How they usually arrest, guys, is they Brady down, okay? That is the normal progression of a pediatric arrest. They lose their respiratory system, then they go into bradycardia, then they go into an asystolic or PEA arrest. That's the normal, okay? So how do we do our transport priorities? Again, urgent, not urgent. Again, if it's an urgent, we do a rapid secondary assessment, transport, and begin our treatments en route. If it's non-urgent, take your time on the call. Don't worry about the 10-minute scene time here. This one here, you got to get your patient's trust. You got to get your patient's, the family's trust. Again, don't go saying, well, we only got 10 minutes on scene. No, we don't, okay? Take your time, do it right. Again, remember that the Glasgow Coma score is modified for our pediatric patients. Yes, I would break out the card on that one, okay? And it's simply, again, are there some equivalencies? Yes, there are. But as far as memorizing it, APHU is fine, okay? Usually a conscious, non-acutely ill child, they transition, they will start to have more problems. So allow the infant to become familiar with you, okay? If they're not acute, let them feel you out, let them figure you out, okay? Sorry, guys. There we go. Now, again, your history, focus your history en route. Make sure you got somebody that can actually answer the questions, or if not, have a phone number of somebody that can answer the questions, okay? Usually when chaos happens, it's always with grandma who doesn't know the history. But again, getting a hold of the primary caregiver of that patient is probably going to pay huge dividends, okay? Primary caregiver is defined as who usually takes care of the child, okay? All right. Again, nature, illness, injury, we want to get this on your secondary assessment. Again, this is your OPQRST essentially, okay? And your sample history, all right? Fevers, how many bowel or urine habits, or more importantly, how they have changed. Are they peeing like they're supposed to? Is there any vomiting, diarrhea, frequency of that urination? All of these things. How long has this child been sick? Okay, yeah, and don't get mad because they've been there down for 3 days, and now at 3 o'clock in the morning they're calling you because the earache's so bad, but now they're not responding. Chances are they're probably a pretty sick kid, and it's going to require some intervention on your part. Okay, so again, the physical head is a toe-to-head exam for the younger kids, head to toe. Once you reach about age 6, go on your feel on that one. Okay. Either way is appropriate, all right? Again, check their pupillary responses. Again, really good sign of their mental status as far as or their brain function. Your cap refill time, boy, I can't stress that. Everybody grab the skin turgor, kind of important for that hydration, and get the pulse ox on them. Okay, that is part of your breathing part, especially in PALS. Okay, your Glasgow Coma score, again, I'm more of a fan of APHU for the kids, all right? Once they get above 6 years of age, then they can kind of fit into the adult one, and then you can use the adult Glasgow Coma score, okay? Take vitals as close to their resting state as possible. Remember, as more that you irritate them, probably the faster their heart rate's going to go, and, again, cause issues. And if you're going to get a blood pressure, use the right size cuff. Don't put the adult cuff on them and think you're going to get, no, put the right size cuff on, okay? Again, hypotension, I'm going to stress this again, a extremely late, I repeat, late sign of this patient is in compromise, okay? So keep that get their pulse quality measures. Again, measure their temperature. We want to check for fever, okay? Fever in kid, not usually pretty good, okay? And observe their level of consciousness. Is the kid looking around? Is the kid, if you say something to them, will they look up and then they'll close their eyes back again? That's usually a really bad sign, okay? Capnography, if you can keep the cannula on them, it's a wonderful thing. The pulse ox, again, that's a really big tool actually, but again, you're going to have a hard time, especially if they don't like it on their little tootsies, or their little finger. You're going to have a really hard time keeping those on. Again, your thermometer, and hopefully you've got one that the swipe. Get an accurate one, and then EKGs, of course. Good luck. What I usually, guys, is I kind of cheat sometimes, and I'll put their stickers on their back. Kind of on the sides or in the back where I can still get a reading. It kind of depends on the child and how sick they are and how well they can. If they're pulling things off, then I usually go to the back on them. All right. So again, you should receive continuous pulse oximetry, especially if you got a sick kid. Okay, capnography. Yeah, boy, it tells us a lot how they're doing as far as putting their metabolism. Okay, so again, if it's available, you should be doing that. Okay. Again, your reassessments of these kids. Continually reassess. You should be doing that. Every 5 minutes for the critical patient, every 15 for and then retake your vital signs as needed, just kind of as the adult. All right, we're going to stop here because we're going to go into the ABCs next. So, but guys, assessment, it is the key and the cornerstone of the pediatric, and that's why I really kind of focus on that, and why I want you to go back and watch that video. If you haven't already, go back and watch the assessment video. It is very important. All right, guys, I will see you on the next one.